Hello and welcome to Unstress. My name is Dr. Ron Ehrlich. I'd like to acknowledge the traditional custodians of the land on which I'm recording this podcast, the Gadigal people of the Eora Nation, and pay my respects to their elders, past, present, and emerging. Now, today we are going to be exploring speech pathology and something called silent reflux, which is a huge problem, which can go on for many, many years and can go untreated and irritate not only the sufferer, but all those around them, as people have chronic coughs and always clearing their throat and may not be enjoying the best of health, even though they could and should. In fact, in order to solve a problem, it always helps to know what that problem is. And so today's episode will be particularly enlightening for many. We're exploring the world of speech pathology as we did earlier last year with Sharon Moore, who wrote the book Sleep-Wrecked Kids. And in that particular episode, we explored speech pathology and myofunctional therapy and the influence that the lip and the tongue and the cheek have on swallowing patterns and airway and predisposing people to nasal breathing or mouth breathing. Well, the world of speech pathology encompasses even more than that. And Nikki Martin is our guest today. Now, Nikki is she's a speech pathologist with over 20 years of experience in both the public and the private sector. And I had the pleasure of being referred to her for my own issue around silent reflux. And I was just blown away by Nikki's holistic approach to this and how far-reaching so much of what she taught me had on so many other aspects of health. So I was really keen to share her with you. And so I hope you enjoy this conversation I had with Nikki Martin. Welcome to the show, Nikki.
Thanks, Ron. Thanks for having me.
Nikki, you are a speech pathologist, and as we've learnt on this program, speech pathology, there's a lot more to speech pathology than people may imagine. It takes many perspectives, and we're going to be talking about some of those. Can you tell us, though, a bit about your own journey in healthcare that brought you to this point?
Yes. So I graduated in 2000, so I've been doing this for a bit of time. And the thing that really attracted me to the profession was because of its broad nature, the fact that you could work with pediatrics or adults, you could work in private practice, public health, you could work in community health centres, disability, ageing populations. There was just a huge broad range. And very similar to what you just said, whenever I mention to anyone that I'm a speech pathologist, most people really only know about the involvement speech pathologists have with children, and they assume it's all got to do with articulation, speech, or stuttering. And so when I tell them actually what I do, they have absolutely no idea that there's any potential for speech pathologists to be involved in those types of areas. So as soon as I did my university degree, I was immediately attracted to more of the medical side of speech pathology. I really loved the acute part of speech pathology and the complex nature of voice and swallow issues. And I love kids. The thing that was a bit of a turn-off for me with pediatrics was dealing with the parents. So I sort of went into adults because I felt that adults had, if they were motivated to do better and change their health, the ownership was all on them. So there was no third parties involved. Sometimes, obviously, you're dealing with carers or other health professionals involved in people's care, but so that's essentially what took me down the path of acute adult speech pathology. It was really interesting. The first day that we started our university degree, they turned around to us and said, look around at everyone. Pretty much 80% of you won't be here by the time, we finish the course, and even less will be here in 5 years' time. And pretty much it's very difficult to get a job. And if you want to get into adults, it's very, very difficult. So 90% of speech pathologists go down the pediatric pathway, and about 10% go into adults. So it's a difficult area to get into. I think it's getting easier now that there are more hospitals and more healthcare centres. But it's definitely the most challenging, and I love it.
You're in private practice, but you have worked in hospital situations as well. That must be a very different thing in itself.
Very different. So I worked in public health for 8 years, and then I worked in private hospitals and nursing homes for the next 4 years. So in acute hospital speech pathology work, it's acute dysphagia or swallowing problems. So it can be, anything from ICU to the burns unit. Even in my first few years, I was working in the neonatal intensive care unit with premature babies or babies born with specific syndromes to stimulate their swallow, and that was super cute. They were tiny. And obviously when you're working in hospital settings, you're working as an integral part of a multidisciplinary team, which is fantastic, and you get to see how all the moving pieces come together in that person's care. It's a lot more stressful because you've got someone's help in your hands, and in terms of swallow function, you can seriously injure someone. Same with tracheostomy management, head and neck surgery. So, but I have a very short attention span. I love challenges, and so that was like highly appealing to me.
It's interesting because one of the things we explore frequently on this program are things that we take for granted, like breathing. We're going to talk about breathing as well, but breathing is a good example. People think, I'm breathing. What else is there? Well, the big difference between breathing and breathing well. And swallowing is another one of those things which people give very little thought to. Tell us what a good swallowing pattern is.
There is no good and there is no typical.
Ideal?
So ideal is that it goes down the right way and doesn't go into your lungs.
Right.
But we are poorly designed in terms of we've got one tube that bifurcates into two tubes. One goes into the airway, our lungs, and one goes down into our stomach. So at that bifurcation point, there is obviously a possibility that food, fluid, and saliva can go down the wrong way into the lungs, and vice versa, air can go into the stomach. Now, we all know what happens when we accidentally, whether we're eating too quickly or we take too big a mouthful, something goes down the wrong way, we go into a horrendous coughing spell, and it's very uncomfortable. But the cough is designed to protect our airway and to prevent any infection. Now, when you have neurological changes, so either directly from the brain or from the nerves lower down, or you've got a direct injury to the throat and those aspiration events start to become more consistent, or there's a phenomenon called silent aspiration where the cough reflex is dampened to such an extent that there is no cough, so food and fluid and saliva are going into the airway unannounced. All of those situations can cause what's called an aspiration pneumonia, and that can be fatal.
Wow. But also, I know that's when we get past the back of the mouth.
Yes.
It's got to go down that right tube.
Yep.
But there's something about the tongue position which helps us ensure that, or what, people, talk to us about.
It's multifactorial. So there are three phases of the swallow. There's the oral phase, there's the pharyngeal phase, and the esophageal phase. So in terms of speech pathology, we're really focused on the oral and the pharyngeal phase and some of the upper esophageal. So you need adequate mastication, you need adequate tongue movement to form a bolus. You need soft palate elevation to seal off the nasopharynx. Otherwise, you can get some nasal regurgitation of food and fluid and saliva. Yes. And you need contractions of all the muscles at the back of the throat to then start the peristaltic movement from the top of the esophagus down to the stomach. So it's a highly coordinated movement and process, and any issues along any step of that process can cause swallowing problems.
Now, I know with kids, getting into a good swallowing pattern is very much part of breastfeeding, isn't it?
Yes.
But things can go wrong even at that early stage, can't?
Definitely.
Tell us a bit about what can go wrong there.
Look, it's not so much in my area. Like I haven't done it for like 21 years.
Okay.
So essentially the swallow mechanism or the swallow reflex gets developed at 32 weeks gestation. So any baby that's born prior to that will not be born with a swallow reflex.
Okay.
Yeah. So you have to stimulate it. And then on top of it, those highly preemie babies have so many tubes in their throat that, again, dampens their swallow reflex. So at that stage, you're looking for tongue thrust, and you're looking for, the big thing at the moment, and again, I'm not so into this, is tongue ties as well.
Yeah.
So they're looking at, curvature of the tongue and whether they can scoop it and then suck it back. But there are so many different conditions. There's like tracheomalacia, where, the airway and the upper airway don't develop properly, and so they're more likely to aspirate. So there's a whole lot of things, but that's not my area.
And then as we get older and some of the neurological problems, you introduced me to this word, which I should have known, paresis.
Paresis, yes.
Yes. Tell us about paresis.
It's not that familiar in the medical terms. I think a lot of laryngologists and people doing this sort of work know about it. Everyone is familiar with the term paralysis. Paresis is really something that I've been aware of in the last 10 years of my profession. So paralysis is essentially total loss of function, and paresis is partial loss of function. So the nerve has been damaged. You don't get complete loss of function, but you can get some really strange motor and sensory results from that damage. So, and it can cause quite profound impacts on voice and swallow function.
And that can go back a long way, can't it? I know we have this idea in chronic pain, muscles have memory, but so do nerves, and that's why they have memory, I guess.
Yes.
This is a good example, because you introduced me to something else, and that was the world of laryngology.
Yes.
Laryngology. Yes. As a speech pathologist, this is your area of specialty.
Yes.
And paresis is an important part of that. Tell us about laryngology, because a lot of people may not have even heard of that.
So laryngology is essentially a practice that focuses on any disorders of the larynx. So the larynx is the voice box, and the voice box is responsible, the muscles of laryngology are responsible for both voice and swallow production. Can I just backtrack for a second to the paresis? Sure. I think the reason why paresis hasn't been mentioned so much until recently, we essentially didn't have diagnostics to be able to perceive it. Oh. So especially, in with the vocal folds vibrate so quickly that if you're looking at it with the naked eye, it looks like they're moving in a horizontal pattern. What they're actually doing is they're moving in a wave-like pattern. And it was only when stroboscopy, and really high definition stroboscopy, which is a light source that flashes at the same frequency that the vocal folds vibrate, that it slows it down and you can visualize that. Wow. And it's only when you can see that you can start to see some slight asymmetry, some like what's called glottal incompetence, which is when the vocal folds don't come together. So there's essentially air leak, so you don't get power behind the voice, and there's obviously an increased space where someone can aspirate through. So I really think it's got to do with, as medical technology advances, then we start to pick things up. And then I look back on my practice, say 20 years ago, and some of the patients that were potentially diagnosed as being hysterical, or it's all in their head, or it's a psychiatric condition, I don't think that was the case. It was because we didn't have the tools to be able to see what was going on, and their symptomatology didn't align with what we could actually diagnose. And so that's changed practice dramatically, I would say, in the last decade.
Wow. That's so common, isn't it? If the practitioner themselves don't know what the problem is, rather than say, you know what, I don't know. Often it's all in your head. You're fine. Yep. And the other one that's interesting is you talk about stroboscopy giving you the opportunity to look at things. In dentistry, 3D X-rays have been a total revelation, even after 40 plus years of practice. So the area of laryngology that I know we met for, and we've kind of interacted on a professional basis, is this issue of silent reflux. And we touched on reflux in several other episodes we did with integrative gastroenterologist Pran Yoganathan and with sleep physician Jim Papadopoulos. But your practice focus is very much on silent reflux. Can you tell us what it is and how common it is,
It's very, very common. And the reason that I've sort of segued into it is that I found that there's a real gap in the market in terms of a lot of these people will report the symptoms, they'll go to the GP or their gastroenterologist, and they'll be put on a medication, and then they'll just be sent on their way. And that's only a very small part of reflux management. And the reason why I really got into it, aside from it, directly affecting my clients, is that I've experienced silent reflux for the last 20 years. And so anything that I have done, and has worked, is what I roll out to my clients. And what I found is that silent reflux can have a really profound negative impact on people's quality of life. So, it can be anything from, consistent throat discomfort, constant voice problems. In extreme conditions, it can cause swallowing problems. It can exacerbate chronic coughs, because it is lifestyle, diet related. And my perspective, I use medication to treat the reflux when it's acutely out of control. I tell all my clients that it's no different to a muscle injury. Once you've got it, you're prone to it. So if you get an upper respiratory tract infection again, or if your diet and your lifestyle changes significantly, you can get a flare up. So they're the times that you're going to be using the medication. But really, long term, it's got to be diet and lifestyle changes, and figuring out the triggers for that individual. And no two people have the same symptoms. So there is not one fit for everyone. So you've really got to spend time with people figuring out what is the triggers for them. How bad is it? Is it more morning? Is it nighttime? Is it exercise induced? Is it more diet induced? And taking the time to go through with them. And as soon as you give people awareness and you educate them, it's almost like a light bulb goes off. I always find it fascinating that how disconnected people can be from their bodies. It's exactly what you were saying before. People only start paying attention to things when things really go wrong. And in some cases, and thankfully not so much with reflux, often that's too late. So, I kind of, try and draw their attention that your body is a highly intelligent organism, and you're taking it on this journey of your life. So you should treat it with the same respect that you're essentially treating everyone else. You shouldn't be dragging it through life. So, it can create quite a profound change in someone's existence when all of a sudden they can resume eating without having a negative consequence. And eating really, other than sustenance for the body, is for pleasure and for connection with other people. And also to be able to talk and not have to be concerned about what's going to come out. How am I going to, sound? Is it going to hurt me? Am I going to have to suffer for the next 3 days because I went out for dinner with my friends? So, it's great when you get a good result, and it's not that difficult to fix. I mean, obviously there are some, people that have structural abnormalities, such as an impairment in their lower esophageal sphincter, certain hernias, etc. So some people do need to take medication long term, but in, I'd say, 90% of cases, diet control and medication to reset the system is enough.
And it's interesting to hear you say you experienced this yourself for 20 years, because, as you know only too well, Nikki, I experienced it for over 35 years, and that manifested itself as clearing of the throat or a chronic cough.
Yes.
So you touched on some of those interventions and make the point quite right that it's personalised. But let's look at those in a little more detail, what some of those interventions are or triggers.
So probably the primary trigger in Western society, I would say, is caffeine and alcohol. And that's what most people consume. People think that having 6 cups of coffee a day, because it keeps them alert, the stimulant properties, they can focus. It is so bad for you. It is a muscle relaxant. It releases the lower esophageal sphincter, and you get free flow of stomach contents, and you can get it all the way to the back of your throat. And because it's silent and because it's not giving you a pain, people can, be throat clearing, have a lump in their throat, and the people that will notice it will be their partners or their colleagues.
Oh, yeah.
It won't be them.
Well, stop at the coffee there, because I remember one of my habits was because I do a lot of intermittent fasting, I might not have my first meal until about 11 or 12. And so in the morning, I did have 2 cups of coffee, and you said, no, all the things you just said. And I eliminated those immediately on your advice. And I noticed, and my wife particularly, noticed a significant improvement. So, yeah, I can attest to that coffee. But interesting to hear you talk about it as a stimulant, a relaxant of muscle, and the flow-on effect. And, coffee is a religion to many people.
Absolutely. And it's the hardest thing that I have to break in people. 2 cups of coffee a day, no problem. Or it's actually 2 cups of caffeine. And that's the thing that a lot of people don't realize. Caffeine comes in many different forms. It's tea, it's green tea. And green tea is probably the biggest misconception. People think that because it's herbal tea, it's okay. It is still caffeine. It is young black tea. So if you're having 6 cups of green tea and you're clearing your throat and coughing, you've got a cause for it, and chocolate as well, and obviously Coke. But like a lot of people are more health conscious.
As in Coca-Cola.
Coca-Cola, yes. Yep. Cocaine's a whole other thing. So intermittent fasting has brought a lot of reflux to a lot of people, and it's something that I've had to morph my recommendations with to satisfy the eating window and the fasting window. And because a lot of people with intermittent fasting often follow bulletproof, so the coffee on an empty stomach with the fats and everything, it is just a recipe for disaster. So
really, from a silent reflux point of view, bulletproof coffee, which I think has got MCT oil and coconut.
Well, some people use butter.
Butter, yes.
Yeah, so it's a high fat source plus very high caffeine source, and you've been fasting for a period of time. And even though your body gets used to it, so reflux can start from having too many acidic items, but it can also happen if your body is hungry and you're not feeding it. Which is what's happening when you're intermittent fasting, because and especially the ones that have a bigger fasting window and a shorter eating window. By the time you're eating, your body is craving food. So if the first thing that you're introducing is caffeine, which is a diuretic, it's a muscle relaxant, and then very high fats, right back up.
I wonder whether this is interesting, because let's stick with this intermittent fasting story, because having said that, I wonder whether it's better to front load the eating part in the first part of the day, because I know we sleep better if our stomach isn't that full. So we may have got this a little bit cockeyed, backwards.
Absolutely. I used to look at my grandparents who immigrated from Europe, and their whole eating pattern was essentially, breakfast is the biggest meal of the day, lunch is the second biggest meal of the day, and dinner is the smallest. And Western society over the last few years has flipped that. And I think that they were onto something, and we should definitely be going to bed, for a start, you should be having a 2-hour gap before you eat and lie down. And that's another way that a lot of people get into problems with reflux. A lot of people eat and then go and slouch on the couch to watch TV. I agree with you. It should be food, then caffeine, and then smaller meals throughout the day.
So what do you say to somebody who has got that window later in the day? What's a good way to start the day if you are intermittent fasting?
I just always say have something to eat first. So just anything. So just anything. It doesn't make because people get into very strong patterns with things. So if they're so set on having their tea and their coffee first thing, and a lot of people do that, I think, to essentially block themselves from feeling hungry for a period of time. So they'll drink. They're cutting down their calories, but they don't realize they're creating another problem. And then they'll have one meal a day later. So what you should do is, even if it's a small handful of nuts, just have something lining your stomach, then have your coffee or your tea.
Yeah. And when you say tea, green tea is high caffeine, what is some tea? Well, I guess some herbal teas.
Well, the hard thing is that with a lot of the peppermint and the mint family is also a muscle relaxant, so it also causes reflux. Yep. So the problem with a lot of the herbal teas are a lot of the main constituents taste horrific. So what they do is they try to mask it with some of the nicer tasting things, and that will be green teas or the mint family. And so you've got a mixed herbal tea that will cause reflux. So the ones that are the best ones, jasmine tea without green tea, rooibos tea, dandelion tea, chamomile tea. And chamomile is probably the best, but the problem with chamomile is most people associate that with having later on in the night to induce sleep. So I'm more resistant to having that during the day. But any of those, and when in doubt, water is your best friend.
Mm-hmm. And you mentioned alcohol, and, I think to anybody that's gone alcohol-free for any period of time, you realise how ubiquitous it is.
Yep.
What's a responsible way of approaching that, apart from complete elimination, from a silent reflux perspective?
Okay, so all alcohol is acidic.
Okay.
Anything with carbonation, so champagne, beers, ciders, they're going to be the worst, because anything with bubbles that can make you burp, it's hitting the back of your throat. Mm-hmm. So then you've got a carbonated drink and an alcoholic drink. And then on top of it, alcohol is a muscle relaxant. So it has the same effects as caffeine when it releases the lower esophageal sphincter. So alcohol in moderation is definitely the best way to deal with it. Also alternating alcohol with water to counteract its diuretic effects as well. And if in doubt, if you do start, the other thing that I tell people is, if you find an alcohol that works for you, stick to it. Okay, white wine is more acidic than red. Rosé is in the middle, and so if someone's a white wine drinker, Pinot Grigio tends to be the more mild of the whites. In terms of the reds, Pinot Noir and Sangiovese, so the lighter ones. And if you have any problems, you cover it with an antacid, Gaviscon after.
Now, you did mention that, and I know that medication is part of the at least short-term approach. You're not advocating it for a long-term use.
Yep.
Talk to us a little bit about these antacid, protein pump, Gaviscon, all that. Tell us a bit about that.
So the reason why LPR or silent reflux is really hard to treat is, like I said before, they're often given a class of medication called a PPI, or there's another class of medication called H2 antagonist. Okay, and both of them are acid suppression medications working with different pathways. So in severe cases, you can put people on both of those medications. You can layer them. So if you've got, because there's two types of reflux, there's gastroesophageal reflux disease, so GORD, which is more the heartburn and you feel it, and that's stomach contents going up the esophagus. And then there's the LPR, so it's the stomach contents going to the throat, so laryngopharyngeal reflux. With GORD, if you put them on a PPI or an H2 antagonist, that alone is often enough to treat it. Now, because with LPR, you've got stomach contents hitting the back of the throat, the lining of the vocal folds is mucosal tissue, which is the same as the tissue inside of our mouth, and it only takes 1 or 2 reflux events before there becomes tissue change and inflammation. Now, there are lots and lots of studies that show even in extreme conditions, when you look at medication and diet control, certain people take 6 months to respond to treatment. Okay, so it's so GORD and LPR are two very different animals and very different treatments. So the reason why a lot of people get put on these PPIs or H2 antagonists, get told to go and then are still not symptom-free, is because when we reflux everything in our stomach, and in our stomach we've got acid and enzymes. So if you're only taking a medication that treats the acid, you're only doing 50% of the job. At the level of the throat, the enzymes are just as damaging as the acid. So you need an antacid like Gaviscon. So you need the two in combination. So either a PPI and Gaviscon, or a PPI and an H2 antagonist and the Gaviscon.
So the Gaviscon focuses on the enzymes?
Yes.
Okay. It's disgusting. I know that.
It is disgusting, but the mixed berry flavour is so much better than the other two, than the peppermint and the aniseed. So
yes, it's less disgusting.
It is less disgusting.
Less disgusting. But okay, so there's that. The other, coming back to paresis, the thing that surprised me as well, because I say I've got a long history of it, was this idea that nerves can be damaged by an old respiratory, viral or bacterial infection, which is a huge issue for so many people when they're younger, or when any time really. We're just living through a pretty big respiratory issue at the moment. But that kind of thing can damage a nerve and affect you for years and years and years later.
Yes, I think they don't know why it happens in certain people and why it doesn't, and why one particular infection is enough to tip someone over the edge. The theory is that in some people that the nerves can lie more closer to the edge of the surface, and then the bacteria or the virus gets in temporarily stops the nerve working, and then when it starts refiring, it's misfiring essentially. So the thing is that with someone like who has a very old injury, the infection at the time can be completely innocuous. It can be a very mild cold, so you don't pay attention, and it can take some period of time for the symptoms from that nerve injury to really amp up. And if you're in that kind of mild category where you've just got like a throat clear or a cough, but it's not really affecting your voice or it's not really affecting your swallow, you don't pay attention to it until something compounds it and it forces you to. So, yeah.
I know that in my own case, whenever I would get a cold or a flu, it would usually take me weeks and sometimes months to get over the chesty, coughy type thing. And I guess that would be a perfect setup for paresis, for damaging nerve and muscle function.
Definitely. And what I always ask people, people seem to have like a predisposition to have specific types of infection. And in my experience, it's either like everyone gets a sinus infection, a throat infection, or a chest infection. And so people have like a weakness in one of those three systems. And it's definitely the people, like you just said, that are prone to these kind of upper respiratory tract infections and cough that are more likely to get these types of injuries.
The other thing is, I think what I've observed is the relationship with water consumption and eating. Mm-hmm. And I know that you go to for example, the worst thing that can happen is you go to a restaurant and someone walks up to you and goes, "Will that be still or sparkling?" And you go, "I'll have sparkling." And they start pouring. And because they want to be good waiters, they keep pouring through your meal. So you are adding this into diluting and fizzing up. You're setting up, it's a perfect storm, really, isn't it?
Totally. And also the big soda stream has exploded in the last 5 years. And people have a real aversion to drinking water. It's something in how we're brought up that we must have flavour with everything that we eat, and water has no flavor, so I'm just not going to touch it. If it doesn't have, if I add bubbles, at least it makes it more interesting. So, so bubbles and carbonated drinks in moderation. Everything in moderation is fine. It's when we start doing things, when we start tipping the scale to more, 60 to 80%, that's when you start having problems. So, so my advice is, cut anything with bubbles down, and you're already like on your way to improving your gastric health.
I can definitely attest to that. And I was a huge bubbles person because I tried, reducing alcohol intake is good. And I thought I'd treat myself with a few bubbles. But you alerted me to the folly of that way. Another thing that you've done, and now, so we kind of talk about the whole coffee, alcohol, fluid intake, antacid intake, and we're talking about for a 4 to 6 month period, really, aren't we? We're not talking about long-term use.
No. So, okay. So in my clinical experience, I can count on one hand how many people have required 6 months medication use prior to achieving partial or complete resolution. So they're definitely in the minority. I'd say majority of my clients are on these medications for 6 to 10 weeks, and then I'm tapering them off.
Oh, great.
Yeah. So
okay. It's even less than that. Yes. Good.
So vague rule of thumb is that the longer the person's had the problem, the longer it takes to remediate the issue. Mm-hmm. So if someone catches it really quickly, so if it's so at the moment with COVID, so if someone has COVID, has been coughing their guts out for the last 2 months, it's generated reflux, I can fix that in 4 to 6 weeks in most cases. If someone has a 30-year history of reflux, it can take longer. But probably the difficult part that I have is people complying with the recommendations. So people are either not great at taking the medication, or they're non-compliant with the diet part, or they'll do some of the diet part but not all. And so if you completely commit to the process and do it for 4 to 6 weeks, you'll get the results.
I can attest to that. And I remember after a week, the first week or two of you were helping me through this, and I came back to see you, and you said, "How's it going?" And I said, "Well, it's funny. I wasn't sure there was much improvement, but when I told my wife I was coming to see you professionally, she said, 'Wow, there's been such an improvement.'" And I go, "Oh, wow, okay." So best to ask your partner or people
Definitely.
around you. So, Nikki, another thing that you introduced me to was this breather fit, and tell us a little. And I think it's fantastic, and I'm kind of really excited about it for my own practice. But tell us a little bit about breather fit, a bit about what it is, how you got onto it.
Sure. So the breather and the breather fit are two devices that come under the umbrella of what's called RMST, which is called respiratory muscle strength training. And both of the devices are both inspiratory and expiratory muscle strength trainers. And so it's a resistive device. And so you breathe in and out of the device. And because you've got a load against the internal muscles, it develops strength and it changes muscle patterns. And the other thing that it does as well is it works on neural plasticity. So if you've got impaired neural connections that are responsible for either voice or swallowing, it can set up new neural pathways to overcome. And so it creates better muscle contraction. So in terms of my practice, it's kind of catapulted all of my clients' outcomes. So traditionally, speech pathology has been centered on, voice exercises. A lot of the voice exercises are focused on what's called semi-occluded vocal tract exercises. So it can range from lip trilling, humming. And what I found was doing those exercises will change the muscle patterns while you're doing them, but it doesn't have such longevity with changing the muscle pattern. What I find with RMST is, and I tend to combine traditional speech pathology practices in combination with RMST, you get long-term permanent muscle change. And the beauty of it is it's a device. People can see it. People are motivated to do it because they can see changes from the device really quickly. In probably about 90% of cases, people can see changes within 24 to 48 hours. It strengthens cough. It improves voice protection. It reduces vocal effort. It improves lung function. There was a study out of, I think it was Colorado last year, that shows that the inspiratory side reduces blood pressure and reduces heart failure. So it's targeted towards not just, voice and swallow clients. In my personal experience, in my personal recommendation, everyone can find a benefit to it, regardless of whether it's, voice, swallow, fitness, breathing. It helps, it reduces snoring. So it's got wide-ranging applications and it's easy to use. People are motivated to use it. It takes 4 minutes a day. So
yeah, no, look, I mean, here is my breather fit, which is just actually nothing more than it looks like a pipe, except instead of a little something to hold the tobacco, it's a ball with two little resistance. One's for the inhale and one's for the exhale. And by twisting the resistance, you up the exercise. And it's literally, I think I'll demonstrate it. You just go.
Slow it down, Ron.
Slow it down. I was just demonstrating that. But yes, okay, no, but that's interesting, isn't it? So slow it down. So it literally is, I'll do it again because I do think it's worth, because we talk about breathing and sleeping and snoring, and here you are talking to me about silent reflux and laryngeal muscles that are affected by paresis. This is what I love about this, the simplicity of it. So an ideal way of doing it would be,
I always get people to inhale first. I find you get more traction. Okay. Yeah. And the way that I try to explain it is that the slower you do it, you're getting more expansion and contraction, so better muscle recruitment and then better strength. Okay. With what you just said before in terms of paresis, so if you've got a paresis, so once the nerve gets impacted, you can have impaired movement, but you can have impaired sensation as well. And once you get impaired movement, there's a possibility that you get wasting of the muscle, and so then you get glottal incompetence. So you don't get the vocal folds coming together. So the device gives you more kinesthetic awareness of what the muscles are doing. What tends to happen with a paresis is you get a compensatory muscle pattern called muscle tension dysphonia, where you've got the ventricular folds, which are next to the vocal folds, and they start to tighten to slam those vocal folds together. So by doing the device, you get retraction of those ventricular folds, so you don't get this, really tight muscle pattern. You get better projection. In terms of the silent reflux as well, it's got a tonal effect on the esophagus, and they're looking at studies, and there has been some past studies on RMST that shows that it can have a tonal effect on the lower esophageal sphincter as well. So there's a lot of positive reports in terms of its effect on silent reflux as well.
And what I've noticed is because of the focus on diaphragmatic breathing while I'm doing this, it's toning up my diaphragm. And interestingly, integrative gastroenterologist Pran Yoganathan mentioned that he felt that reflux, gastroesophageal reflux, is more a function of diaphragmatic sarcopenia, which means underdeveloped diaphragm. So when he said that from a gastroenterologist, and you give me this, which also, apart from toning up my laryngeal and pharyngeal muscles,
it essentially has a tonal effect from all the muscle groups from your perineum up to your nasopharynx.
Yep, which is another aspect of that. That was the other thing. Perineal tone is something we all need to improve as we get older. I mean, certainly for women after they've had children, and for all of us as we get older, toning up the pelvic floor muscles. And this is what I love about this. It's kind of taking this looking at the whole body effect of what's going on here, and probably improving digestion in the process as well.
Absolutely. So, like I said, it's got so many applications, and it doesn't make a difference. What I find really interesting about it is, I've had some clients that, I can have a marathon runner, and what is a marathon? Is it 52 kilometres?
I think 42.
Is it 42? Okay.
42.
You would think
Last time I did it, I went through the wall at around 2 or 3, and the rest is a blur.
Okay, no. I don't understand you people. You would think that someone who would be able to, who's got the capacity to run those distances, would be good at breathing. No, I can have a marathon runner who's got an impaired breathing pattern, and then I can have an 80-year-old woman with Parkinson's who's better than the marathon runner.
Wow.
So there's a lot of, discussion, about breathing, and, we can get into funny breathing patterns from illness, from infection, trauma. Often it makes people hold on to things and start breathing in a really shallow range. So there's so many reasons why we get into non-beneficial breathing patterns. And, I at one stage was looking at becoming a yoga teacher, and the theory behind that yogis believe is that we are born with a finite set of breaths, and that once you expend them all, that's when you pass away. So if you, and I don't know whether that's true or not, but I thought that was a cute
It's a nice idea.
It's a cute idea.
Yeah. No, I like it.
But it's really interesting when you look at it like that. And it's like, if you do have those finite breaths and you're expelling them in a really quick, non-productive way, don't you want to change that, and don't you want to improve your quality of life and also extend your life? So, yeah.
And as we've covered on many episodes, the breath has a tremendous impact on every system in your body, both physical and mental. So the idea of breathing slower and gentler, extending your life, whether it's a numerical thing about saving up your breaths, but it certainly impacts in a positive way on your body and mind. That's what I love.
Can I just say something about that quickly, Ron?
Yep.
That's one of the feedback that's sort of the feedback that I get from a lot of the clients, that they actually perceived going through the exercises with the breather or the breather fit as meditative.
Yes. And interestingly, when you mentioned humming or other exercises, and I know didgeridoos are very good for toning up those muscles, but what I love about this is you could literally put it in your top pocket, and it's very accessible and achievable. Gee, Nikki, the more, we've spoken, professionally, one-on-one many times, and this has been so good to bring it all together into one conversation. I wonder if, as we come to an end, I wanted to just take a step back from your role as a speech therapist, as a health worker, because we are all on a health journey through life in this modern world. What do you think the biggest challenge is for a person on that journey?
I think with modern day life, I think we're so distracted, and I think it's, more pronounced now with social media and access to information. I look back to growing up and everything, and life was a lot simpler and less complicated, 20 years ago. I think being grateful for the body that you've got, taking good care of it before there's a problem, and enjoying, like being present and enjoying everything and being grateful. I think gratitude is probably the biggest key to life. I think most people look at what they don't have rather than taking stock of what's working for them and trying to build on that. So yeah, I think life is to have fun. So, and if you're not having fun, you're doing something wrong. So yeah.
Well, Nikki, what a great note to finish on. And I'm extremely grateful to you for joining us today and everything you've done for me professionally. And I wanted to share you with our listeners. So thank you so much.
Oh, thank you for having me. I'm really grateful as well. It's been a lot of fun.
Thanks.
Thanks.
So there it is, a whole branch of speech pathology that is called laryngology and focusing on a common problem, a really common problem. And I can attest to it, and Nikki attested to it herself, that silent reflux is something that affects many people. And it's manifest, as we said, with throat clearing and coughing, etc. And in my experience, that's what I loved about Nikki's approach. And the more I talked to her, the more holistic the approach is, really, because here she is talking about how to consume fluids to minimise the chance of reflux. But in the process, by consuming them in the way that she's recommending, you improve digestion. I mean, at the end of the day, stomach acid, and it's very acidic. I mean, it's got a pH of something like 2 or 3, which on a pH scale, it's amazing that it doesn't burn a hole right through our body, because if you dropped acid of pH of 2 onto your skin, it would most certainly burn a hole right through your skin. So think about that. The pH in our stomach is there for a reason. And it's there for 2, I think, main reasons. One is to break down nutrients into their components, which can be then absorbed and used to rebuild parts of our body. That's what nutrition is all about. That's why we focus on a nutrient-dense diet, because we want those nutrients to be broken down and for them to be available for us to rebuild our body optimally. So particularly, that's what stomach acidity is all about. And of course, breaking down meat, you do need good stomach acid for that. So that is one thing, but it's also antimicrobial as well. You forget that that actually the outside world is really the inside world, with a tube running through the middle of us, and that starts in the mouth and it ends in our anus, and that is an external opening to the world. So this is why the stomach acid is also so important, because it's antimicrobial. And that's why I actually have a real problem with it's one of the problems I have with long-term use of antacids, which is very common. I mean, some of you may know somebody, or maybe yourself, on a protein pump inhibitor like Nexium or Somac. They are called blockbuster drugs because they generate over $1 billion worth of sales every year. And the reason they do is because reflux, heartburn, and indigestion are such a common problem. So, of course, it's very easy in a 10 or 15-minute consultation for a doctor to prescribe you with a protein pump inhibitor, and that is a symptom-based approach to healthcare, which is very common in our society. The problem with that on a long-term basis is that you do not break down and therefore absorb your nutrients as well as you might, and you are more susceptible to things like osteoporosis, which, of course, there is another medication for. You could be on on bisphosphonates. Isn't the pharmaceutical world of medicine so wonderful. For each ill, there's a pill. And it's a great economic model. It's just not a very good health model. The other problem is that it makes you more susceptible to infection. Well, yes, you could take antibiotics as well. The other problem is that long-term use of these kind of proton pump inhibitors may also affect your ability to sleep well, but hey, guess what? There's another medication there. So it's far better to explore how you are consuming your foods, number one, and that is particularly in relationship to the fluids that you're consuming and how you're consuming them. And I think it's a good rule, as is not to drink while you eat, and probably not to drink for about 10, 15 minutes before you eat, and not to drink while you are eating, and perhaps to wait another 10 or 15 minutes before you continue to drink. So that's another thing. So when you picture yourself in a restaurant with a very attentive waiter filling up water all the time, or even worse, filling up carbonated water all the time, that may not be the best move. So it's not just how we eat, but it's also what we eat. There may be foods that you are sensitive to, and this is another issue we've raised several times on this program, that there's a difference between food allergies and food sensitivities. Food allergies is when you eat something and you break out in hives or start sneezing immediately, and that's an immediate allergic reaction. But sometimes allergic reactions are delayed and may take several hours or a day or two to manifest themselves. So you might not realise that you are sensitive to those foods. I also love this breather fit, and here it is, breather fit with an exhale gauge and an inhale gauge. It's about the size of a pipe with a little ball on the end, and different resistance levels. And I love the way it's not only toning up muscles in the pharynx, which as we get older become looser and make us more susceptible to snoring, but it also helps us tone up diaphragm and our pelvic floor. And, the more I learn about the diaphragm and the pelvic floor muscles, the more important it is. So this simple little device helps all of that. Look, we'll have links to Nikki's site, and she is a wealth of information, and she's a terrific professional. I can certainly attest to that. And another page in our discovery of what speech pathology is all about. I hope this finds you well. Until next time, this is Dr. Ron Ehrlich. Be well.
This podcast provides general information and discussion about medicine, health, and related subjects. The content is not intended and should not be construed as medical advice or as a substitute for care by a qualified medical practitioner. If you or any other person has a medical concern, he or she should consult with an appropriately qualified medical practitioner. Guests who speak in this podcast express their own opinions, experiences, and conclusions.